wait for a couple more minutes, but then feel like we should just get going because we have a lot of stuff to go through. There will be a time for the end for questions if you have any questions, but we're keeping this super casual as well. So if you really have a question you want to ask, you can raise your hand and we can try to get to it. But there will be follow-up after this. But we're just really grateful to have everybody here. And I will, with that, pass it off to Ben to kind of get us going.
All right. Thanks, Rachel. Super excited to have everyone today. So we're going to cover what's going on and what we're seeing within the behavioral health landscape, especially around the pressures around speed of responding, and how do we help patients not have to wait between where they're at in their care journey to getting the treatment that they need. So I'm super excited to have Michelle and Lynn here today to join us in the conversation. So I'm Ben Hackett, founder and CEO of Basalt, and we're focused on no patient waiting, which is how do we help patients who, especially in acute situations of mental health needs, how do we get them into the facilities where they can be most supported? So we're located here in Nashville, and we use AI to help us identify and read large patient packets, and then help determine if they're a good fit for the facilities that they're being referred to. Joined today with Michelle Schafer. She's CEO at the Mental Health Cooperative here in Nashville. Michelle is just an incredible human being in general as well. I had the opportunity to hang out with her just at her offices last week. So what's interesting, and I think there's like no one in the space who like lives the values between the work that they do and the patients that they serve. So like at her offices, you have patients across the street where they have their facilities, and then you have the business offices. Literally, there are patients who will walk into the business offices. Maybe they're drinking coffee or watching TV, and that gap between the patients that Michelle serves every day and the patients in the work she does running the business is it's just so beautiful to see. I'm so excited Michelle's here and to get her perspective for the folks that she serves. We have Lynn Simon, former president, healthcare innovation. She was the chief medical officer at CHS. She's a senior advisor at 25M Health. Total badass. Lynn is just knows the tools and the way you run operations at a large health system, especially on the clinical side. Like, how do you take the right tools to support and amplify the work, to serve patients really well, and just has decades of experience really helping support patients and clinicians, which is so important in this work. So super excited. We got an incredible crew today. So why we're here again, it's to serve patients, especially in the behavioral health space, which is how do we determine and help where they're best aligned to the care that they need, both in the moment, along their care journey, and then as they recover from their conditions. And so the way that what we're seeing out there is there's this really strong focus on, especially in places where there's a large number of discharging hospitals. So if a patient's in the emergency room, that patient needs to be discharged to a facility of care in BH where they can be served well. There's a huge push to say, hey, I got to get this patient into a better level of care, let's say outside of the emergency room, which has led to a compression around how do we get these patients to those facilities quickly. And if you're an admitting BH facility, what you see is that you have to respond quickly to be able to determine if you can admit that patient. And so what that means is we're seeing just significant challenges around things like missed clinical details. So let's say a patient has been discharged from the hospital or is in the process of being discharged. You receive, I'm sure everyone here has experienced this, you get a 60-page fax. Your admissions team has to determine in oftentimes in competitive markets like Arizona or Florida in sub 5 minutes whether you can admit that patient. And so if you have 60 pages of clinical packets, you have to determine, okay, does this patient meet our facility criteria? Are they on continuous oxygen dependency? If so, then, that's potentially red criteria for our facility. There's a self-harm risk that we have to be considerate of. We may not be able to admit that patient. Is the patient's vitals, is their blood pressure too high to a point where we can't meet those clinical needs? Being able to do that across 60, 100 pages quickly is something that's actually impossible for a person to do today. The second component is what gets missed within those records. So, if we miss that a patient has, let's say, is on hemodynamic monitoring, or they have recent aggressive behavior against a clinical worker, if those things get missed, we're now placing patients who don't meet the clinical facility criteria that we need to do to support both the patient, but also the clinicians who work in those facilities. And the third piece is how do we make sure that we're not creating admissions that lead to readmissions from the discharging hospital, which is if we're really not in a position to be able to support this patient, the last thing we want is them to go back to the emergency room. And so how do we identify, treat that patient well, make sure they're successful, such that both for patients and our clinicians, they're set up really successfully. So what's happening today, there's a story I heard a bit ago of a patient that was admitted to a facility. So that patient had about 60 to 100 pages in their patient packet. The team, instead of, I think this is like no fault of clinicians at all, but with sort of the pressures around time to review and admit that patient, what'll happen is they'll call just the discharging facility. They'll call the discharge nurse and say, hey, tell me about this patient. I don't have time to read whatever, all 100 pages of what's in that document. So what happened in this scenario is there were components of that patient record. They ended up admitting the patient, but buried within on deep within that patient packet was the fact two missed opportunities around a recent aggressive behavior against the discharging facility of that patient. That led to that patient harming two of the clinicians within that facility. And I think what pains me about that story, and I think where we see that struggle is all of that is avoidable if we had the ability to quickly read what goes on within that patient record and to quickly determine, hey, is this patient both at risk to themselves or to the facilities where this patient is potentially admitted? And how can we sort of fix this challenge, get to better patient outcomes, as well as protect our workers and still represent the sort of competitive nature within the market. Perfect. We've got the expert here in the room. Michelle, do you want to sort of share what you're seeing out there related to behavioral health? Maybe some of the issues you see around delay and the patients you work with every day.
Yeah, thanks, Ben. And welcome everybody here. Thanks for spending your time with us to hear about the innovation that's going on at Basalt. I think that you will find that it's actually pretty exciting, especially for folks who have been in healthcare a while, like Lynn and myself have. We've been really hopeful for something like this for a long time in terms of a tool to help us. I have been doing care and behavioral health, substance use disorder, actually my entire career. Most of it really in large healthcare systems. More recently, a little bit across the street on the community-based side. But just have a lot of experience for this. For those who probably live it every day, I won't spend a ton of time identifying for you problems that you know about and that you're seeing and living. I just kind of want to focus on and reiterate the disruption and the pain and the issues that it is really for the patients, the consumers, the people that we serve, every single day. As you know, over the course of the last, almost decade, obviously the needs for behavioral health and substance use disorder care have been rising, got a whole lot worse post-COVID, and really haven't trailed off. And we're seeing it younger and younger and younger, seeing it certainly in adolescents, but now in very young children as well. At the same time, not as many resources as are needed are available for folks. And ultimately, unfortunately, Hospitals and health systems have been the de facto, right? Folks don't know any place else to go. So they end up they take themselves, they take their sons, their daughters, their loved ones to the emergency room, hoping to get access to care. And the important thing to remember here for everybody, obviously, is that there's a couple of things. First and foremost, when people are seeking help and they have no place to go, that they are in significant crisis, in significant pain, and it's a personal thing for them, obviously. And unfortunately, emergency rooms are really kind of the last place you want to be. My emergency room colleagues are amazing individuals. They do life-saving things every day, and they are there to treat cardiac events and stroke events and motor vehicle accidents and broken bones and all the things that you would expect an emergency room to do. And then all of a sudden, they have a whole lot of behavioral health or substance use disorder folks who need that help as well. But they often didn't have the exposure or the training or the resources available at their fingertips to be able to provide the care for those individuals. So it takes a huge toll on the person that's in crisis, and it takes a huge toll on the healthcare providers that are in those emergency rooms, or oftentimes, a lot of times in rural hospitals that are put on a medical floor to try to clear out the ED because they don't have a whole lot of space in the ED. You all know that this is happening, but it's hard oftentimes to remember what it is the patient is going through and or their family. And so not too long ago, we had a case, an individual with, it was a mom, and it was her young child. And I do mean young child. Her child was 5 years old. And they unfortunately were in a pretty difficult situation at home. And what was obviously staggering to the mom, who was also experiencing this difficult home environment but wanting to protect her child, is that her 5-year-old was actively suicidal and looking for an opportunity in a 5-year-old's capacity way to not be around and be in that environment anymore. And the only thing that she could think to do was to wrap something around her neck and try to harm herself. And that is, as you can imagine, it's devastating. It's devastating for that child to be in that space. It is devastating for the mom. That's without question probably the worst day in that mother's life. And so they went to an emergency room, and despite everybody's best attempts, they had difficulty in terms of finding a hospital bed and finding one timely for that individual. And so what happened with this child is the mom is there, the child is there, they're in crisis. They're not, the emergency room, the hospital didn't have the resources to be able to actually start care. And we were in a situation where that child didn't wait for 3 hours or 4 hours or 5 hours. That child waited for nearly 3 days to be able to get to a place that could provide that care. So the child and her mom were in an emergency room, sort of just living in the emergency room, being checked on and cared for as best as that ED could possibly do. But they didn't have the resources. They didn't have the behavioral health resources at their fingertips to be able to start any kind of direct care for the child or her family, to really understand what kind of medication potentially needed to be, the child needed to be put on. Nothing but just kind of basic overall, this is a presenting problem. Here's what's going on. And there'd been outpatient, there'd been other things that mom had tried to do, but then they're in this situation where they're constantly faxing and sending information over and over and over again to facilities to try to get a bed. And they also are in a situation where they didn't have the resources to do that. So you have nurses that are trying to facilitate the right kind of care for a family. And you have that family that's in the midst of an emergency room, which is an extremely scary place for a child just in general. But for any of the people that we serve, any of the adults any of the families, quite frankly, any parent that's in there with the child. I often used to say that people like to go to the hospital potentially when they're having a baby, as long as everything's perfect. But otherwise, hospitals, although very needed, can be a very scary place because people are in some level of crisis or health crisis. And so being in a situation where then you can't effectively, quickly get to the care that you need creates an entirely additional traumatic toll on the patients that we serve every day, because they're exposed to the waiting, to the not knowing, to the scary place that they're sitting in, to folks that want to do their best to possibly help, but they can't. And I know that many of you are, you're living this every single day, where we are trying to decompress our emergency rooms, right? And we're trying to get people to the right place. I've been in situations where we have referred people out, found a hospital bed for them, only for that same facility to end up sending them back for potentially a healthcare issue. Maybe it's blood pressure, maybe it's blood sugar, maybe it is a potential for violent behavior that they didn't see in the packet. And then the situation for that particular patient is they got in the hospital, they waited and waited and waited, they got sent to a facility, and all of a sudden they got put in an ambulance and sent back to the hospital originally, and they have no idea why. All they know is that they want help, right? And so we're all living with that every day. And unfortunately, because of the resources not being able to meet the needs, this is a consistent situation that is in hospitals. It's talked about nationally. Quite frankly, it's talked about outside of the United States, as we all try to figure out the rising way to address and to intervene at a much earlier stance with people who have mental health and substance use disorder. So the important thing is we've got to make changes now. We have to understand how we serve both the people that have the disease states that we're serving and the individuals in hospitals that are trying to care for them in a much better way. It's something that we in healthcare have been struggling for a long, long time. And I'm excited to be a part of this webinar and for you all to hear about something that, as a healthcare leader myself with lots of years in hospital systems, I see this as a real opportunity to truly make impact and difference, and leverage resources. And I know that'll make a difference not only to the patients we serve, but those who are trying to serve them every day and don't have the resources that they need. There's also significant impact, as you might imagine, on the caregivers who are trying to do their absolute best. And I'm gonna hand it off to my colleague Lynn here and let you talk a little and have her, give a little bit more information about the impact to operations and the caregivers themselves.
Right. Thanks, Michelle, and happy to be here today to hopefully talk about solutions to the problem. So thanks for giving that description of the patient journey. It's heartbreaking, but I think we all know and experience that. But the weight on the team is sort of the next problem. We want to help our staff and our teams be able to function better. Being a healthcare worker is a challenging job, and people come with their passion and everything, 110% effort every day. But I think there are ways to lighten the load on the team and help them do their jobs better. And so you described really from the operations perspective what happens in the emergency department. And I think that's one of the weight on the team is the referring facility and how the referring facility has challenges taking care of patients. And I think in the past, our solutions have been, well, we build a unit within a unit, or we have telepsychiatry. But at the end of the day, the patient still stays there for 3 days. That's not the right answer. And then, we have the operational challenges of left without being seen because of boarding. So there's something has to be done differently than the solutions we put in place. And on the accepting facility side, there are different pressures. We've talked a lot about them as, they go through hundreds of pages of faxes and emails to try to make the right decision. They're really charged with using their beds most effectively and efficiently. But they also have to balance, what's the criteria from the payer? What are the criteria for our facility? And each facility may be a little bit different. And so that could be challenging as well. And then they're in a competitive environment. So they do want to get to yes sooner and try to make that happen for their organization. So I think the bottom line is really that the medical staff and the clinical staff and the admission staff, they know that the decision to admit or the decision not to admit has just big implications both for the patient, for the referring facility, and for the organization. And they're just trying to do the best they can to make the best decision. You can go to the next page. I'm sorry. For I think the as leaders, what we see, and I think what Michelle talked about and others is, we need to try to get the tools in the hands of our team, and really that all goes down to people, process, and technology. So we have great people. They come dedicated every day. We keep working on the processes, but what we really haven't added is really the technology. And what that technology should do is make it easy for people to do the right thing for both the patients and the staff. So how do we surface the information that the staff could be highly confident that they're seeing all the information? And if they make a decision on that, they're going to have fewer surprises and get to better decisions more quickly. So again, the people, process, and technology to make it easiest to do the right thing, both for the patient and the organization. And with that, I'll turn it over to Ben so he can show you how that works.
All right. Thanks, Lynn. Yeah, so
Yep.
let's talk about this in practice and how do we improve these outcomes in the real world here. So if you'll go to the next slide, we'll go through a quick demo here, but really what we're trying to achieve is how do we choose patients that meet our facility criteria, that are the right patients where we can serve those patients and make sure our staff is safe and secure. How do we not have any surprises? So anything that we can identify within the patient record that matches our facility criteria the first time. And then also, how do we support being able to make these decisions quickly? There's a ton of pressure to be able to make these decisions fast, both for and be on behalf of the patient, but also on behalf of the facilities. So how do we do that with high quality and with speed? So super excited to share what that looks like with a quick demo here. All right, can you see my screen okay? Perfect. Okay, let's look at we've got a patient here. So we're going to review, let me pull this up here. We're looking at a Jane Smith. So on the left here, what you're going to see, this is the view that either our referral coordinators or clinicians or facility CEOs use to review patients where we've received referrals. So on the left here, these are patients that have come in, that can come in via fax, can come in via email. You can upload new referrals directly. So some of our customers have folks who are embedded in the discharging facilities, or maybe they're directly pulling that information from the EMR and uploading manually. In addition, I saw there was a question around what about sort of the vendor portals. We are able to also pull and integrate with those vendor portals, things like state bed boards, to pull in those referrals automatically as well. So we know that fax oftentimes is a limiting function in the sense that it can take about 30 seconds a page to receive a fax. And so we support any way that we can grab a referral. So someone described this sort of as like the portal of portals. So our job here is to aggregate any patient referral that comes in here and then be able to determine, hey, does this meet our facility criteria? So the first step in this is you'll see here we're extracting out all the patient demographic information, their contacts, things like the referral source or the accepting facility. This here is really to help support how do we essentially just grab the information we'll need to put into the EMR or that we need to know about this patient to register them. So you don't have to read every page. We extract this out. If you want to edit any of these components, then the facility teams can go ahead and do that. And then we can push this directly into the EMR or into Salesforce, whatever sort of the endpoint is, where we're going to end up reserving that patient bed. The next component is where we start reviewing all the clinical information. So we sort of separate out the clinical documents from the administrative documents. And essentially what we're doing here is we're running this against the facility criteria. We're in a demo environment here, obviously, so this is super fast. It's really fast in production as well. Typically what you'll see is Depends on the number of pages, but let's say for a 30-page fax, it'll take us about 30 seconds to review every page in that patient record and compare that against, let's say, the facility's criteria. So let's go through that now. So here what we're seeing is this is the facility's criteria for can we admit this patient? What is the red criteria, the yellow criteria, and green? I'll show you in a minute, but we're flexible on a per facility basis. So if you have a facility in Texas that accepts and works with minors, but your facility in North Dakota does not work with minors, there's flexibility to determine, hey, which patient and which facility are we looking at? So the first step we take is we review every page in the patient record, and then we provide a summary of where we've identified that patient against facility criteria. So in this case, this patient is on active dialysis, which would be a red criteria for this facility. And then we provide the source evidence and the highlighting of where that exists within the source document. So in our demo session here, you can imagine this is a PDF. We've highlighted that source item and then provided the exact page number so that if we're looking at a 100-page fax, we navigate directly to the source of where we found that. Our job is not to make the final determination. It's how do we find all the evidence such that the clinicians or the coordinators who are doing this work have the evidence. And one of our core product sort of viewpoints is that any statement of fact is grounded in source evidence. Super important. And this is where we see a ton of the speed, which is we aggregate all the information, put this in front of someone who's the expert, and then give them the opportunity to make that call. In addition, you can see here we have a high risk alcohol withdrawal. You really have the ability to define, okay, what types of patients are we able to support? We can do this by blood alcohol level. Really, any clinical criteria that you have, we work with you to determine what are the specific criteria that we want to highlight. And then you can see here the yellow criteria. Typically, this we see goes to like a nurse-to-nurse review. And so what you're able to do with Basalt here is you can always send this patient to someone else within your organization to do a nurse-to-nurse review. And with that, they see the same patient and same evidence. And what's cool about that is that you can also have a conversation about that patient together. So what you'll see up here in files and notes is I can go ahead and leave a note. I can tag someone like Lynn and say, hey, I'm seeing no recent aggressive behavior that is concerning. And then with that, you can have your nurse-to-nurse review super quick. All this gets documented. It is fully auditable. And any decisions that get made, you can collaborate across your team. The other huge benefit of this is it gets us out of email. So one thing that we worry about a ton is overall patient privacy and security around PHI. Anything we can do to get notifications and communication out of email is so important. We've seen issues where in previous organizations I've been, you type the wrong email, you send patient information, like it's a huge issue. And so keeping all the status within a single tool is really helpful here. The other component is we also run this against clinical appropriateness. So if there are payer rules that you use to determine, hey, do we have reimbursement sort of approval here, or do we have the documentation that will support reimbursement? We can run those rules against the patient criteria as well. Again, this is both super helpful for the health systems we work for, but also with patients in the sense of, look, at the end of the day, if we admit a patient and care is not reimbursed, that can absolutely have an impact on the patient's financial liability here. And so whatever we can do to pull this information out, and again, you'll see the same citations exist here to support the evidence with the payer. We also show a clinical summary and overview here. So this is where we support, hey, just like tell me what's going on with the patient, whether that's things like their overall height or any wounds that may exist. any medication the patient is on, we can pull and extract that. This is fully configurable for the facilities we work with. Everyone has sort of a different clinical summary they're looking for, either to put into the EMR or to understand what's going on with the patient. It's funny, I think this is where we get a ton of love from clinicians specifically, which is the ability to just quickly understand what's going on with that patient. At any point, you can also review all the files that we have on that patient. So if you want to review the source documentation or download those, you can view those directly. You don't necessarily have to review it as we've outputted it here within Basalt. The next component is around financial, which is how do we make sure that we're prepared for the patient, both from an insurance perspective, i.e., do they have active insurance, and then from a reimbursement perspective. So in this case, we'll pull the patient insurance information. We run the verification check automatically. So as we extract the member ID, we send that off to determine, okay, is the patient eligible? And then a benefits check as well. On top of that, one of the biggest issues is, do we have the proper documentation to support maybe a pre-cert or pre-auth on a per payer basis? So we're able to pull those payer requirements and then determine, hey, do we have and have we met the payer requirements for reimbursement related to this patient? And then we also pull the supporting documentation that's required for submission. We're working on a feature right now. We're close to completion that will allow you to also have Basalt submit that pre-cert or pre-auth on behalf of the facility, and then manage both concurrent reviews and the appeals process. So because we understand what the payer requires, because we understand everything within the patient record, that sort of same ability to determine, is this patient a good match clinically, is the same access and determination to say, hey, let's go ahead and gather the right information the payer is going to need to determine that this patient is a good fit. Another really, I think, important point here that I want to share is around the red, yellow, green criteria. So one thing we see within our customer base is that oftentimes each facility has their different rules in how they define their clinical criteria. And what's, I think, interesting about this process as well is sometimes these things are sort of not fully defined, i.e., the internal policies at a health system. Sometimes they don't even know their own internal policies as they vary across facilities, but also they're vague enough that if you imagine you started at one of these facilities, you may have questions about how that gets defined. And so what we do is we provide the back end sort of like administrative tools to say, hey, let's go ahead and provide you the access to adjust your rules as they come in, but also codify them as a source of record across all of your facilities. So we support these at, like, again, the parent level. So let's say your health system has parent rules, and then let's say your facilities can subscribe to those rules or change them. So maybe one facility, again, accepts minors, one doesn't. You have the ability to go and adjust these rules. Where this is also super helpful is you may find, like, hey, we've defined recent aggressive behavior as occurring within the last 2 weeks. Well, what we're finding is that actually that's too broad of a range. We want to limit that to 1 week. Within Basalt, you can adjust those rules, and then any new patients you process or any historical patients you want to reprocess changes immediately the criteria you're searching for. Super helpful in being able to, one, look across all of your facilities, but then two, make changes that are best for patients and your staff. Now, like, you have to be an administrator to be able to access these tools. Where these, to me, one, are I would say, like, super important and are not something we share with other customers, but also directly impactful of patient care. And so we really only want the most senior clinicians being able to adjust these rules. The other cool thing is you can also just send this to the clinical team as well and be like, hey, can we verify whether we consider let's say, uh, chemo within these criteria. And again, go ahead and quickly change this. Um, Historically, what you would have to do is train your entire team, do a huge amount of communication. Here, you can go ahead and change these rules and let the folks working know, hey, this has been updated, and they'll see that change within the patients. Perfect. And if anyone has questions while we're going through this, feel free to ask and interrupt. No worries.
Ben, someone had a
Yeah.
question that's more towards the beginning of this process, but they asked, can you share more about what comes after fax integration? And are you seeing any data blocking from vendors in the referral space?
Yeah, great question. So fax obviously is limiting in speed, and so what we provide is the ability again to receive those referrals directly from email. So we essentially set up a forwarding address, upload those directly, and then from groups like the bed boards or some of the vendors we see out there, in which case we're monitoring those for new referrals. So our goal is how do we get these referrals as quickly as possible to make a determination, and so we enable this outside of the fax space as well. Anywhere we can grab that referral. We haven't seen any pushback there. I think obviously it's an emerging space, which is that the ability to like make these decisions quickly is going to impact the market. In our view, the sort of the rules and legislation around patient treatment access for these treating facilities is precedent for being able to access and manage these referrals directly through the source that they come from.
Sweet. That last question was anonymous, which I really like. It's a safe space here. You can ask these questions anonymously. But we did get a question from Nick. Have you seen any efficiencies in the process with carriers?
Yeah, definitely. I mean, I think this is like another, this I feel like could be its own webinar, which is what is the role of AI within especially around like pre-cert and pre-auth, which is, the payers are using agents on their end to help make determinations in a similar process, which is, let's take the interqual rules, for example. Does this patient meet the interqual rules or requirements for our reimbursement purposes? I think, in my view, that it's not really quite a fair game in the sense that they're using agents for those determinations, but I think are holding back from allowing providers to do the same thing. I was talking with a group who they have voice agents that will call the payers. Well, what the payers have started doing is asking, "Hey, are you a voice agent?" And then if so, then they hang up on that call. A little bit unfair in the sense that that work occurs on the payer side. Um, on the health system side, it's a little bit different when we think about accessing that work via a website where those sort of direct access is a lot more straightforward. Where we see the efficiencies improvements again is within searching and finding the appropriate documentation. And so each payer will have requirements, in which case our ability to go find that within the exact patient clinical records, the exact page, download that, and then submit it directly. That's where we see a huge amount of the savings. No one has to like that same clinician before who had to read every patient page to determine if they can admit had to occur on the reimbursement side within these health systems as well, which is, go read every patient document, determine which ones we're going to submit to the payer, and then go about that process. Here we can do that, search all that information and provide that directly, which fundamentally, like, it feels like a little bit of an arms race. But if we again think and focus back on the patient here, which is how do we help determine whether this is going to be reimbursable if they do get something like a denial, or we need to help appeal, that we found all that documentation to support them financially. And if we talk about BH, um, this is a population that needs as much support as possible, and the last thing we want to see is any financial burden where 1 in 3 Americans now have medical debt, like we got to get to a place where we prevent that as early as possible. Okay, perfect.
Cool. I was just
I'll show, yeah,
you
I'll show one last thing around reporting. Or did you have another question, Rachel?
no. No,
Okay.
but please ask more questions if anybody has any more questions. I had a question, but I will wait for the end.
Okay, cool. The other really big component is on reporting, which is how do we think about our performance as it relates to the referrals we're receiving? So, one of the biggest components is understanding things like what's our referral to admission rate? Like, are we doing a good job of meeting what we would expect to meet on the amount of patients we're able to admit? Obviously, we don't want to go to a place where 100% of patients are admitted because not every facility can treat every patient. So it's bad for everyone. But really understanding, okay, across our markets or across our organization overall, how are we performing? And how do we make sure that we have targets around, hey, we think this is the right referral to admission rate. Let's monitor our performance. We can also show things like the volume by market, where we have referrals in different statuses. So are we seeing, for example, 31% of our patients within the benefit check ready status? How do we speed this section up such that we can get patients through faster on this step of the funnel? We can also look at things like how are we doing on payers or denials by provider by payer as well. So do we see higher rates by particular payers? Why does that occur? Do we need to go back and say, hey, let's work together on making sure that we, if we're doing something wrong on admitting patients, let us know. Otherwise, we need to have a conversation about approving these patients in totality or at a faster rate. And then from an operations perspective, things like what's the median time each patient sits in each status? This to me is where I think we found the most places to dive deep with our customers, which is, hey, we're seeing a ton of time spent in the pre-cert. Like, do we need to wait before we make a decision? Or, hey, we're spending a ton of time in benefits checks prior to doing the clinical review. Do we need to wait for that to occur? And so being able to monitor how you're performing in real time, day to day, across getting in a patient admitted, uh, we found has been super, super helpful. If you also want to check like, hey, across our team, like, do we need to have some performance conversations around, hey, we see that, one of our referral coordinators, maybe who's newer has too many patients that aren't making it through to a final determination. All that reporting across teams, you see this across markets, maybe where we have individual referrals that are stuck for multiple days, providing all the insights to determine, hey, how are we getting patients so they don't have to wait and we can make a decision really quickly. So our goal is to Lynn's points, support the operations teams as well to do their jobs well on behalf of patients and the clinicians. Cool. With that, I think we can go back to the deck, but also maybe check to see if any questions in the room.
Yeah, I'll pull up the deck here in a sec, but I was going to ask all of you, we talked a lot about the problems, and I just feel like every time I read the news or Becker's, it like feels like we're up against it. But yet everybody feels super optimistic in this. And so like where are like you seeing these things that are giving you hope in the space right now? Where like are there success stories happening and not just the scary stories happening?
Was that for us, the panelists, or the audience? Sorry, Richard.
Sorry, for the panelists, these
Okay, cool.
Ben, Michelle, and Lynn.
Michelle, you want to go first?
Yeah. Well, I think I obviously think that healthcare, and I'll speak relative to behavioral health here, okay, because that's the area that I have lived in. We have been kind of behind in terms of historically being able to advance for a myriad of reasons. Not a lot of research, not a lot of money for that, stigma, you name it. And so we're in a sort of a fast pace to catch up. We're also the area that at times historically maybe had the factors first, that either payers or other folks tried to put controls around in terms of reimbursement and other things. And I definitely see that changing, in that behavioral health is more a part of the overall healthcare conversation, that there's recognition about behavioral health and the importance of it in the overall health of individuals. And then overall, in general, I think that there is a move to better understand how we, who historically have kind of been behind in adopting things, can leverage tools that are out there to better serve our individuals, and not do it just according to older models, relative to processes, relative to direct delivery of care. An example that I'll give there is the adoption of telehealth as kind of a big innovation in behavioral health. Before that, before COVID, no way, right? I mean, it was like the last thing possible. COVID mandated it for darn near everybody. But then when we were able to go back to care directly, you didn't see a big drop off in behavioral health in terms of the adoption of that type of technology. So I use that as an example about how I think mindsets are changing, and that then enables us to be able to look at technology and lean in technology to figure out how we can do things better, especially in an industry that is very under-resourced. So we have a lot of folks who really, really need access to care and can't get it. So we have to figure out how to spread further and do things differently. And I look at technology as a friend to that, so that we can meet the needs of more people and intervene quicker.
Yeah. I mean, the only thing I'd add is I think we are seeing an uptick in adoption, AI adoption, and the similar tools being adopted with health systems. And I think this is a perfect example of, starting more on the sort of clinical administrative side. You're not making decisions, as far as medication decisions or health, kind of direct medical decisions for the patient, but you're facilitating the people that know what the right thing to do and what they need to do. You're just facilitating them to make better, faster, and probably more standardized, as Ben mentioned, more standardized decisions versus maybe being sometimes a little arbitrary in how we make decisions. So I think this is a great example of what people would figure is a reasonable risk to implement these kind of tools, and it would really support the team in a major way. I see the slide there mentions implementation. Maybe it'd be great to have Ben talk about that a little bit before we go.
Yeah, perfect. Thanks, Michelle. Thanks, Lynn. Yeah, on the implementation side, yeah, it's pretty straightforward. A lot of we integrate with a lot of the different fax vendors to pull that patient data in. Email is pretty straightforward. Essentially, the process is just what are the sources where patient referrals are being received, and then working with the clinical teams within the health system organization to make sure that we have the right rules. I think oftentimes, like with any process, once you start saying, hey, let's review things like, what vitals we should flag on, it opens up this broader conversation of, well, should we adjust these vitals? Is systolic blood pressure of 140 too low for us to consider that a nurse-to-nurse review? It creates, I think, a really helpful standardization and a relooking of that clinical criteria. But it's essentially just taking that list and then adding that into the way our models search over the patient record.
What,
So we go ahead.
can you talk about EMR integration, or whether
Yeah.
there is or isn't, that may be helpful for folks too?
Yeah, and then we integrate with all the different flavor of EMRs. So happy to do that process. Typically, what we find is that it's more pushing into the EMRs for a couple reasons. One is to place that patient where bed capacity is sort of tracked. And so reserving that bed capacity is part of Basalt. And then also making sure that we have all the patient records and checking for uniqueness as we push that in. We can also pull from the EMR. That's totally fine as well if that's where patient data is landing. In that case, we essentially just grab that from the EMR and then begin processing and then can push it back. But happy to do that on a bilateral basis. Some folks have Salesforce, either Health Cloud, or use that for sort of intermediary between Basalt and the EMR. Um, and then if we need to have an accessible data warehouse where we can share either the reporting or some of this core data, we're happy to set that up as well. But implementation, typically takes probably about 2 to 3 weeks. Most of that is just working with the clinical team to make sure that we've got the right criteria, and then running some historical patients to make sure that we're all really happy with the outputs.
Yeah, and I'll say, like, as one of the newest members of Basalt, I am so impressed at how customized the experience is for each different client. I was like, "Oh, we must have like 20 engineers working here, but we have a small, mighty crew that is so good at working with the needs of each specific clinic. Um, and so I feel like implementation seems pretty seamless and it's also super customized. We have another question and it's from Anonymous, and it says, who is the best person to contact if we want to learn more about how this would work within our organization? I don't know if they're talking about people who to contact, like who's the person they talk to within their organization or within their company, or if they're talking about at Basalt. So I'm gonna ask you both of those.
Perfect. Yeah, happy to reach out to myself or Rachel. My email is ben@basalt.health or rachel.stevens@basalt.health. Happy to help. And then if there's a question about within the organizations, typically, it's the operators that we work with, VPs of admission or directors of admissions, is who we work on a day-to-day basis. There's also a contact form on our website as well. But yeah, just shoot me an email, ben@basalt.health.
Great.
Perfect.
Does anyone have any other questions before we give you some time back in your day? Well, thank you all for joining us. We'll send a follow-up and we'll send the recording of this if you want to share it with anyone else as well, or go through the parts that you were eating lunch through. But thank you so much, Ben. Thank you, Michelle. Thank you, Lynn, so much for making this happen. I think this work is so important, and I'm really excited to see the changes being made in this space.
Yeah,
Thanks,
thank
Rachel.
you.
Thanks,
Right.
Michelle.
Thanks,
Thanks, Lynn.
Rachel.
Bye.